Hi, my name is Dr. S, and today we're going to discuss uh, abdominal compartment syndrome. But before going to the aspects of this disease, there is a brief history regarding this disease. Uh, in 19th century, a physician begins recognizing the increased pressure inside the body compartments could impair blood flow and organ functions. In 1948, Robert Cross described staged abdominal repair in infants with large abdominal wall defects. In 1982, Harman and the colleagues demonstrated that elevated intra-abdominal pressure could reduce renal blood flow and causes oliguria, strengthening the thick link between abdominal pressure and organ failure. In 1984, Cron and the Greeks gave the first clear modern description of the syndrome. In 1990, ACS became increasingly recognized in trauma, vascular surgery, burns, and critically ill patients. In 2004, a society was built, and that is WSACS, which established to standardize definitions, diagnosis, and management of the disease. There is a brief description of this disease. ACS is a life-threatening condition in which the pressure inside the abdomen rises to be a dangerous level, usually above 20 mmHg, and begins to impair the function of vital organs inside the body, such as kidney, lungs, heart, and intestine. It can occur after a severe trauma or major surgery, internal bleeding, bowel obstruction, pancreatitis, or massive fluid accumulation can be a part of this disease. As I told you the description of this disease, increased intra-abdominal pressure causes new organ dysfunctioning or failure. Diagnostic threshold intra-aortic or intra-abdominal pressure resist more than 20 mmHg plus new organ dysfunction. Uh, Core concept: pressure, perfusion, emergency, vessels, organs, diaphragm are compressed. The mechanism, uh, the trigger, bleeding, edema, ileus, sepsis, burns, or massive uh, uh, resuscitation. Uh, Increase volume, like blood, fluid, bowel distension, or generalized edema. Increase intra abdominal pressure. Abdominal wall cannot compensate the pressure. Number four, compression causes decreased venous return, decreased renal perfusion, increased diaphragm pressure. Organ failure, renal failure, respiratory failure, shock, or bowel ischemia may result in the increase of, um you can say, the pressure of blood. The high risk groups, uh, if you can go for the primary ACS, trauma, bleeding, abdominal surgery, bowel obstruction, pancreatitis, and intra-abdominal infections. Secondary ACS, massive fluid resuscitation, sepsis, burns, capillary leak, and generalized edema. Recurrent ACS after previous treatment may occur, uh, alter clear, uh, repeat monitoring needed, uh, decompress if organ failure persists. Emergency signals are very important. Tense abdomen, oliguria, high airway pressure, hypotension, shock, lactic acid or lactic acidosis uh, may cause or may be caused by the disease. ACS organ effect, intra-abdominal pressure, if raises, it causes decreased organ perfusion, increased diaphragm pressure, and multi-organ failures. Kidneys, renal failure, decreased renal perfusion, oliguria, anuria, raising creatinine, need strict urine output monitoring. Uh, in case of lungs, diaphragm pushed upwards, hypoxia, high ventilator pressure required, low tidal volume, difficult ventilation. Heart circulation decreases, venous return, hypotension, shock, and poor tissue perfusion. Decreased mesenteric perfusion in the bowel, bowel ischemia, lactic acidosis may result, and risk of necrosis and perforation. In liver, hepatic perfusion, abnormal lefties may result metabolic dysfunction and monitoring of hepatic status should be there. In brain, that is very important. Venous congestion may worsen. Intracranial pressure may raises. Neurological risk in severe symptom shock may happen. You have to remember one thing: ACS is diagnosed by pressure plus organ dysfunction. Um, Imaging helps find the cause but does not replace uh, intra-abdominal pressure measurement. That is the diagnosis. How to measure IAP. Bladder pressure measurement, patient spine and expiration, zero transducer at mid-axillary line, repeat in high-risk patients. Sport assessment, urine output, uh, because there is a decline of urine perfusion, urine functions decreases, lactocitosis, creatinine, and renal function may disturb hemodynamics, and imaging to identify the cause may be needed. If the ACS has confirmed sustained IAP decreases 20 mmHg plus new organ dysfunctioning or failure, this is a clinical emergency. ACS treatment, that is the stepwise treatment reducing intraliminal volume, nasogastric tube, rectal tube, or bowel decompression may needed. Improve abdominal wall compliance, analgesia, sedation, neuromuscular blockade when appropriate. Remove intra-abdominal fluid, precautionist drainage of ascites, blood, pus, or collection may be needed. Optimize fluid and perfusion, avoid fluid overload, that is very important. Diuresis, RRT if suitable, and maintain perfusion is required. Surgical decompression, emergency laparotomy when severe, progressive, or refractory conditions are there. Non-surgical measures, gastric decomposition or decompression, uh, clonic decompression, drain ascites, collection, avoid light binders, support ventilation or perfusion, correct sepsis, bleeding, and coagulopathy. Surgical use when organ failure is severe or refractory. ICU care may be needed. Infection perfusion or infection prevention may be needed. High risk patients, trauma, sepsis, pancreatitis, burns, and surgery. Um, ACS may be suspected in intense